Welcome back to Women's Health. This is Dr. Kim Malone. I will now present Chapter 145, Fertility Control. In the United States, 99% of sexually active women have used contraceptive at some time in their lives. And as of 2010, 62% of women aged 15 to 44 reported they are currently using contraceptive methods. The definition of contraception or birth control is the act of preventing a pregnancy. And that's done through medications, procedures, devices, behaviors to prevent a pregnancy. In 2015 through 2017, 64.9% of women used some form of those birth control methods, and it's looked at as upon a patient's choice to choose their contraceptive method that involves factors of looking at efficacy, safety, non-contraceptive benefits, the cost of the method, and personal considerations. Following information is based on CDC recommendations and the World Health Organization. You as the practitioner need to know that these guidelines that 1, no lab testing is necessary before contraception is initiated. 2, no physical exam other than a BP check is needed before initiating a combined hormonal contraception. 3, cervical cancer screening is not needed before IUD placement. And 4, IUD removal is not necessary if the woman develops PID. An antibiotic treatment is sufficient if the clinical improvement is demonstrated. Let's begin with combined hormonal contraception. Combined hormonal contraception is the prevention of ovulation and prevention of pregnancy, therefore. It's a combination of a mechanism of action of 2 steroids creating a synergistic effect that greatly increases their anti-gonadotropic and ovulation inhibitory effects. Lots of words. Prevents ovulation, prevents pregnancy. These contraceptives alter the consistency of cervical mucus that affect the endometrial lining and alter tubal transport. Combined oral contraceptive pills are taken daily at the same time each day to attain efficacy. Oral contraceptive pills do not protect against STDs, therefore condoms are recommended. So see contraindications for use of hormonal contraception on slide 6. A little more about hormonal contraception that your book emphasizes is that understanding the use of combined hormonal contraception. Estrogen is one of the 2 of the hormonal components in combined hormonal contraception, or CHCs. And the role of estrogen is to promote bleeding regularity and suppress the release of the follicle-stimulating hormone. These estrogen compounds are delivered with a synthetic progestin, and the second active hormone compound is the progestin. The progestin component provides the majority of the contraceptive effect by suppressing also the follicle-stimulating hormone and luteinizing hormone. Some of the side effects from combined hormonal contraception pills are nausea, breast tenderness, mild fluid retention, and that results from the estrogen component of the CHCs. They are very common signs and effects. Menstrual changes, including intermenstrual breakthrough or spotting, occurs in about 25% of women during the first 3 months of use of CHC. And it decreases significantly as subsequent prolonged use happens. Other estrogen-related side effects would include increased breast size, weight gain, and increased skin pigmentation. Women with persistent intermenstrual bleeding after 3 months of CHC should be evaluated for possible causes of bleeding unrelated to the combined hormonal contraceptive. So looking at the use of CHCs, some of the benefits extend beyond that of preventing pregnancy. The woman will experience lighter menses and result in a decrease in the incidence or severity of iron deficiency anemia also. Hormonal contraception. There are different methods. Let's begin with oral contraceptives. Oral contraceptives are probably the most prescribed form of contraception in the United States. And the first oral contraceptive regime provided 21 days of active hormone followed by 7 days of inert pills, resulting in withdrawal bleed. Now, those methods might have changed, and there are different options. But overall, approximately 25% of women use this method, which prevents ovulation. It's also used for treatment for menstrual irregularity, prevention of ovulation, and it can reduce Mittelschmerz. Women with secondary anemia to menorrhagia increase their iron stores. The FDA has approved the use of several extended OCPs, or oral contraceptives, that result in the withdrawal of bleeding once a quarter. And with the perfect use of OCPs, the effective percentage is 99.7 to prevent pregnancy. Another type of contraceptive method would be a vaginal ring. NuvaRing being the most recognizable today, and it's a non-biodegradable, flexible, colorless ring that is inserted. This device delivers progesterone or progesterone-estrogen combinations, and this combination of contraceptive vaginal ring is a new form that's approved recently. This ring is worn 3 weeks and it's removed for 1 week to produce menses. The third method, combination contraceptive patch, is applied and worn for 7 days for 3 conceptual weeks, then removed on day 22 for 7 days when the period is expected. After week 4, a new 28-day cycle is started with a new patch applied. This is not effective for women with a BMI of 30 kilograms or greater. So if your patient comes into your clinic and is obese or morbid obese, this would not be one option and that you would give to that patient. The excess fat would prevent the efficacy of such a method. Progestin-only products known as the mini pill is a mechanism of action that includes suppression of ovulation. It has a variable dampening effect on the mid-cycle of LH and FSH, two important hormones. And it has an increase in cervical mucus viscosity, a reduction in the number of size of the endometrial glands, and a reduction in the cilia motility in the fallopian tube to prevent a pregnancy. The fourth injectable contraceptive method is a monthly injection of combined estrogen and progestin to prevent pregnancy. 3 types are Depo-Provera, Cinera Press, or Neuraster. Depo-Provera needs to be administered every 3 months, and it works for 5 years. Here are a few illustrations of the different types of birth control methods that a woman has the option to choose. You see there are 2 basic types of IUDs, a hormonal IUD and a copper IUD. The copper IUD also can prevent pregnancy and has been around a long time. Hormonal use either a single or a combined type of hormone. Next we look at the patch, and you see the patch can be applied in various places for the best efficacy, and that's the upper torso, the buttocks, the upper outer arm, and the abdomen. The contraceptive implant is applied on the inner aspect of the upper forearm, and you see that that's a small rod that is surgically implanted either by the NP or physician to prevent pregnancy. Birth control rings, you see they're flexible. Sometimes they're hard to insert. They need to be inserted properly. The diaphragm is next, and that is a cone-shaped type of device there that also needs to be inserted into the vagina correctly. And then the Depo-Provera injection. Continuing on with combined hormonal contraceptive methods, you see contraceptive implants, and we saw a picture earlier on the previous slide. This is a mechanism of action that combines the suppression of LH surge, suppression of ovulation, development of viscous and scant cervical mucus to deter sperm penetration and development. That small rod is inserted under the skin to prevent birth control. It prevents pregnancy up to 4 years and releases progestin into the body. Another method is postcoital contraception, and this is postcoital oral emergency contraception is used for the prevention of pregnancy after intercourse. It's commonly called the morning after pill, and common methods of this are Plan B or that copper T IUD that prevents implantation. Intrauterine devices, there are 3 that are common in the United States. Copper T 380, it's T-shaped polyethylene IUD with a fine copper wire wrapped around the vertical stem. The Liletta or Marina, which is common, is a T-shaped polyethylene IUD with a reservoir that contains 52 milligrams of levonorgestrone, progesterone. And Kyleena is a T-shaped IUD with a reservoir that contains 19.5 milligrams of levonorgestrone. Now let's look at some of the risks for CHCs. The low risks for using a combined hormone contraception would be venous thrombosis, hypertension, atherogenesis and stroke, hepatocellular adenoma, and cancer. The contraindications, and you must know this, if you have a patient that comes in and is discussing contraception with you, what would definitely be a contraindication for the use of a CHC would be if the patient has a history or an episode of cerebral vascular disease or coronary artery disease. Have they had surgery? Do they have a stent? Do they have a history of a heart attack? Do they have chest pain? Such questions need to really be explored. History of DVT, PE, and CHF. You see they will be at risk for those, so if they have a history, it eliminates this choice of contraception. Untreated diabetes with vascular complications and hypertension is a contraindication. Estrogen-dependent neoplasm, breast cancer survivors or those in treatment definitely cannot use these types of CHCs. Undiagnosed vaginal bleeding, active liver disease. Any patient that is older than 35 years, it's a contraindication to give them a CHC because of the risks. And cigarette smokers. So if you have a patient that is a cigarette smoker, they cannot use oral contraception. Warning signs to teach the CHC users with acronyms of ACE. And this is really, it comes from your chapter, but it's well done with the use of an acronym. Abdominal pain should be reported. Is it severe? It can indicate liver disease. Do they have severe chest pain, cough, shortness of breath that can indicate angina or PE? Headaches that are severe. Do they have dizziness, weakness, or numbness? This can indicate stroke or a hypertensive emergency. Vision loss or blurring. Are there any eye problems or speech problems that can indicate a stroke? Severe leg pain in the calf or thigh may indicate a DVT. All those need to be reported immediately to the practitioner. Women who experience any of these signs or symptoms or who develop depression, jaundice, or a breast lump should discontinue the pill and consult the provider. Women who smoke should be encouraged to quit, and if that is not possible, then should discontinue CHCs after the age of 35. Now let's switch and talk about barrier methods to prevent pregnancy. Most common, definitely the condom. Male condoms are popular. They're the mechanical barrier to prevent sperm from entering. Provides the most effective protection of the genital tract, and this one also prevents STDs. It's 98% effective. There's also such a thing as a female condom. This prevents pregnancy by acting as a barrier to the passage of semen in the vagina, and it's 95% effective. Both can be bought over the counter. Diaphragms prevent pregnancy by acting as a barrier to the passage of semen into the cervix. And this device is sometimes difficult to place in the vagina, so the patient's going to need some instruction. The inner ring may cause discomfort, and it's a shallow silicone cup that covers the cervix. A pelvic exam and a measurement is done to determine the correct size when the patient chooses this option, and it's inserted 6 hours before intercourse with a spermicidal cream or jelly, and it's 86% effective. Cervical caps act as a barrier to sperm migrating into the cervical canal. The cap must be filled with 1/3 full of spermicide to be effective, and the efficacy is at 86%. Spermicides prevent from entering the sperm from entering the cervical os by attaching to the sperm's flagella and body, reducing the sperm mobility, and that spermicides have an 82% efficacy. Cervical sponges are small pieces of white plastic foam inserted into the vagina up to 24 hours before sex with 76 to 88% effectiveness. Emergency postcoital contraception, which are ECPs, emergency contraceptive pills. Most common use, this method is the over-the-counter Plan B. And Plan B, one step over-the-counter, is an enteric-coated contraceptive type of pill with levonorgestrel that dissolves and is absorbed in the intestine. Ovulation is inhibited. There's an effect, and it's effective until the LH surge. Copper T380 IUD, like I said earlier, it has a foreign body effect. It creates a toxic milieu within the vagina and cervix and uterus, preventing implantation, not effective for emergency contraception after implantation has occurred. Permanent contraceptive methods. That is surgical sterilization. For the female, that includes permanent prevention of fertilization by interrupting the fallopian tubes. The fallopian tube sterilization in the postpartum period with small transverse incisions can be performed with fallope tubes or rings, clips, bands, or segmental destruction of the fallopian tube with electrocoagulation and suture ligation. Males who choose permanent contraception through vasectomy involves incision of the scrotal sac, transection of the vas deferens and occlusion of both severed ends by a suture ligation and fulguration. Remnant sperm remain in the ejaculatory ducts, and the man is not sterile until sperm-free 15 to 20 ejaculations. The failure rate is 0.1%. Histoscopic sterilizations, such as Escher system, does not require surgical incisions and are performed under local anesthesia. This is not done anymore in the United States since 2018. In other countries, a hysteroscope is inserted in the fallopian tubes under the local anesthesia. It was removed due to problem with the placement of micro-inserts into the fallopian tubes with poor outcomes. Other methods of planning would be natural family planning, and in the world, it's one of the most widely used methods of fertility. It does not protect against STDs. Many of those with religious and cultural beliefs that do not have the option of other contraceptive methods and devices use this type of natural family planning. This method involves periodic abstinence during a woman's fertile period, which is around ovulation. A calendar is used in cervical mucus or is carefully observed. Used with regular and predictable cycles, and it requires a lot of discipline, so the failure is relatively high. Periodic abstinence, coitus interruptus, you see that people, especially younger, active adolescents, may use this, and you see the failure is high. Its failure is 22%. It involves the entire withdrawal of the penis from the vagina before ejaculation. Fertilization is prevented by the lack of contact between spermatozoa and the ovum. And you see the probability of pregnancy is high with incorrect use or inconsistent use. Lactational amenorrhea, that means the mother who is breastfeeding. Evaluated prolactin levels and reduction of GRH from the hypothalamus during lactation suppresses ovulation. This leads to reduction in the LH and inhibition of the follicular maturation. The duration of the suppression varies and is influenced by the frequency and duration of breastfeeding and the length of time since birth. So this method requires breastfeeding to be specific every 4 hours during the day and every 6 hours during the night. No supplementation of formula or other foods, and no return to the menses. And a baby must be younger than 6 months for perfect use. If this criteria is not met, then they are a chance for pregnancy. Thank you for your attention, and I hope this review has been helpful.